Thank you, Andrew. Wow, panel. What a setup. So we are very fortunate to have a panel from across the country with, I think, really diverse perspectives. I want to move immediately to that discussion. I'd like to ask each of you maybe to provide a very brief self-introduction, and then we'll have a few minutes for each of you to share after that your perspectives, and I'd like to get into a broader discussion because I think there's tons here. Paula, do you want to begin?
So I'm Paula Chidwick, and I'm the ethicist at William Osler Health System, which is just north of Toronto here.
My name's Aimee Sarti. I'm an intensivist in Ottawa, and I've led a multi-center investigation of family member experiences in Ontario that really led into a national study now where we've been interviewing family members across the country about their experiences around end-of-life care and organ donation decision-making and processes and bereavement. And we've been really fortunate to have the opportunity to talk to now over 200 family members across the country.
So, as you heard, I'm Jason Shaheen. I'm a pulmonary intensivist in Montreal. Main focus is on research and on prediction modeling, and also, as you heard, looking at differences in end-of-life care.
I'm Murat Slesser. I'm an adult intensivist from London, also clinician scientist and a regional medical lead for Trillium Gift of Life.
My name is Andreas Kramer. I'm an intensivist and neurocritical care consultant at the University of Calgary. I work mainly at the Foothills Medical Center, and I'm also the medical director for the Southern Alberta Organ and Tissue Donation Program.
Okay, thank you, everybody. We had an opportunity before this panel to have a brief call to discuss, and I shared with the panel how Andrew and I had kind of conceptualized it and framed the discussion, and almost immediately Paula did it better. So I would like to ask Paula to start us off and sort of frame for us your sense of the issues we're discussing and the tensions and some of the things that Andrew opened us up with.
Okay, thank you. So when I was thinking about these tensions, the question I asked myself was, I started off with tensions for who? And who is defining the tensions? And does this matter? Are the tensions the same for physicians and staff versus family or patients? Or are the tensions seen a little differently for families versus the patients? So there were different things that, can be found that have been talked about today, like the guidelines, for instance, outline the tensions from the lens of preserving the public trust through minimizing a real or perceived conflict of interest, or recognizing that there may be ethical tensions around accelerating death and not treating suffering. That was one set of potential tensions. We learned yesterday, and we'll hear more today, around what families may perceive as tensions about wanting to donate, wanting it to go ahead, or the death taking too long, being present or not being present at the death and after. Families may disagree with a patient's decision about pursuing maid donation. A husband may not want his wife to know he has chosen withdrawal. So these are tensions from a family perspective. And then I also found myself thinking about the perspective perhaps from the patient. And they may experience tensions around the consent process. Do they feel that healthcare professionals trust them when they are providing consent? Who decides if the autonomy has been safeguarded? The patient, who says, I'm not coerced. So, and that would be in cases of first-person consent. And do patients feel more confident about their wishes and donation than we do. So the tensions for who? Are all these tensions the same or equal, or are some tensions more important than others? My panel members will answer all these questions. Lastly, one last comment was about the lens that we use will in some way frame the solution that we look for. We want to be clear about what the problem is and who the problem and for which the problem is for. So I'll pause there and go on with the other panel members.
Murat, you and I began working together at TGLN a few months ago, and I was saying last night, one of the things that I've really enjoyed is, as you've come officially into this role, some of these questions that you're, bringing forward in terms of, I have these experiences as a clinician and as a researcher, and explain to me how these things fit together. Could you share a little bit about your thoughts around this and some of the tensions that you've perceived in your roles that you've held?
Sure. I think for me, the tension revolves around the healthcare provider at the bedside. And when, although I do acknowledge there's tensions for other players in this process, myself as a healthcare provider, having experienced a DCD, or withdrawal of life support, and 15 minutes into the process, that this patient may not be eligible for a liver. The experienced bedside nurse knowing that most likely time's running out, and the family turning around to you because they've been informed by the organ and tissue donation coordinator about the timeliness of the process, the family turning to you and saying, "What are you waiting for, doc? We're going to lose this opportunity to donate." And I think and so you find yourself in the middle of this process with everyone looking at you, and you have these tensions of your responsibility to the patient and honoring their wish, also maintaining the autonomy and well-being, your responsibility to the family who you've met when the patient first arrived and who you've taken through the initial resuscitation treatment process and then withdrawal of life support measures decision. Your responsibility to the team who's standing by and with you in the process and looking at you to answer the family member and to make the right choice. The immense amount of healthcare resources that have been utilized to make this particular event happen. And of course, the existing current ethical frameworks, the legal frameworks, and your own moral compass. And what's challenging, I think, is that you are, at least I can acknowledge that I'm ill-prepared to make the informed or rational answer to this family in the heat of the moment, so to speak, because you do have to make a decision. You have to rationalize that decision. And then you have to communicate that decision to both vocally to those present in the room, and then hopefully in a written format as you document the withdrawal process. And so I think if we can acknowledge as a community that these tensions exist and come together like we did for the first time in the room yesterday and start speaking about this honestly and openly, I hope that we can prevent the feelings of guilt that we've heard from the family member yesterday of wanting their loved one to die faster in order to for the donation to occur. Prevent this feeling of second loss when the patient takes too long to die to have an opportunity to donate. and ultimately the moral distress of our healthcare providers at the bedside who have to go through these experiences on a daily basis. So I think that would be what I took away from the masterclass, and I think it's great that we're talking about it in this forum.
Thanks, Murat. As you alluded to, we had the privilege yesterday of having patient family participants in our discussion. Aimee, I know it's a big ask, which I seem to do to you a lot, but if you could, from the perspective of the national research you're doing, give some representation to the things that you're hearing from our families who are going through a DCD process or donation process, and give us a perspective on that.
Sure, and I think I'd first just start off by saying the national study is ongoing right now, and we have had the opportunity to talk to those through cases of NDD, DCD, those who could donate, those who could not, those who declined, those who agreed. So we've got a really comprehensive cohort of family members' experiences that we're really looking at, but it is ongoing, and we are still analyzing the data. So really kind of just looking at some big bucket kind of preliminary ways and drawing from the Ontario experience as well. And I think when I really thought about coming to this and that kind of opening around whose tensions and tensions for whom, and when I interview family members or read through the interviews that we've done, most family members don't talk about it like that. They don't describe it to us as though they're experiencing a tension. They describe an experience, an emotion, challenges, things that were hard, things that were done really well, and they go through all of these different issues, but I wouldn't necessarily label it as a tension in the vast majority in the cohort that we're having the opportunity to interview. I would say that I think overwhelmingly, and it's really important for us to know that family members are highly happy with the end-of-life care that's provided by the team overall, that we're hearing overwhelming positive messages about the care that's provided and the trust in the teams that are looking after them. But within these positive experiences, and also, again, the very important experience of having the opportunity to donate, as I said, we're learning the opportunities to improve. So maybe to highlight a few areas that I think that we can talk about more, again, looking at what family members are telling us. One thing, again, leading up to the withdrawal of life support, I think really critical is preparing the family member, and for a number of things. And one thing that comes out in the guidelines is the importance of being prepared for the actual withdrawal of the ventilator and of life support and what that looks like. And that's not always happening. Family members are not infrequently telling us that those moments they weren't really prepared for what they were about to witness, and having more information would be helpful. Now, we also have to recognize that family members tell us that they're in a chaotic state of mind. They're tired. It's the worst day of their life. They're experiencing all of these things. So even stuff that we think we may be telling and communicating may not be being heard. So we have to be careful and cognizant of how we're communicating with family members. And the second piece of preparing a family member, I think, is critical, is for the potential that donation may not occur. And as was mentioned about the gift of trying, but making sure that it's very clear that going through this doesn't guarantee that. And that if there's other pieces of the end-of-life care plan for them as a person and a family, that we allow time to focus on those aspects as well, and other rituals or spiritual pieces that family members have really shared are individual and different, and incorporating that as part of the package. The second part of the kind of process I would like to just highlight from what family members have shared is what is happening during and the environment of that withdrawal of life support, often in a very sterile environment. And we've heard stories of the lights dimming down low and chairs being brought in and the family members coming close and them urging us to hold hands and be with them and play music, and that we knew they were outside the curtains but they gave us space. On the other side, we've heard bright lights and things feeling very sterile and not feeling like I could get close, and having a feeling that people are peering outside the curtains. So we are hearing different messages on the environment, and I think that that's a critical piece that we need to look at. Then the third and last part I'd just like to highlight is the transition. And a part that really struck me that, in fact, I think surprised us as a team is the number of times that family members have now told us that when the body has been taken away to the operating room in cases where death did occur in time, how alone they've felt. and how they have felt that in instances there has not been a support person there for them in that moment, and they didn't know what to do. And in one very striking example, I remember interviewing a man, and his infant son had had a traumatic brain injury, and they went with him to the operating room door and went into the operation room, and the boy was taken away, and he was left standing outside with his wife and alone. And he said it was the most empty and horrible feeling could ever imagine. And he told me that it was so important to make sure someone's there with the family because he didn't know where to go or what to do or what the next spot would be. And that's occurring in DCD and NDD. So those transition points are critical. And on the other side, when donation does not occur, that transition back to the intensive care unit, I think, again, is critical. And the support that we provide and the emotions that we're hearing about, that people are feeling these emotions. They're feeling guilt or sadness, disappointment, or maybe they're not feeling that. Some people don't feel that. They say, you know, I was prepared for this, and we knew we might come back, and so we had the support of the team there. So it's very individual, but I think giving a space for people to express their emotion, to normalize that, to share that other people have felt those things as well is really important. And so obviously there's lots we can talk about there, but maybe I'll just pause. Thanks.
Yeah, just I know that in the talk you gave us, you cautioned us that this is preliminary and should be taken with some grain of salt. But in your own experiences in the work that you've done, are you seeing things that inform the questions and the tensions we're talking about?
Yeah, I mean, you heard the work that was done. I think it's important to say that work really comes out of personal experience and the tensions that I have felt or my colleagues have felt. And they're very real and very tangible. If I could just share an anecdote or two quickly, and because these really have formed my thinking. One of the first DCDs we did at one of our hospitals in Montreal, my mentor did it actually, the head of the ICU. And he said it was, I'll be honest, he said it was an awful experience. He said he was in there with the family, and it was, as you described, bright lights, very sterile environment, and the clock was ticking, and all he could do was look at the clock. And he said he gave doses of drugs he was honest that he hadn't given for airway obstruction and so forth, but it was a traumatizing experience. And I think more so for him is that the nurse who looked after the patient who was in there with him was equally traumatized and was in, I'll use the term, was in moral distress. The actions that she felt were happening were against what she was used to for whatever reason. And it took her a while. He said it took her a few weeks to get over this sensation. And it was really a palpable experience of distress that they both had. This was early on. And so the question that he put and that I think is raised is that, you know, we talk about it being the same, but how can it be the same? I'll get back to that in a second. But a second anecdote is a DCD that I did with a colleague of mine where I was a second physician. And it was the usual, we extubated, there was some airway obstruction. And my colleague, who again is one of my senior colleagues, says this is ridiculous. I put in oral airways, nasal airways all the time. I could treat this in 2 seconds. And I said, that's not my process. And I discussed with him, and he was well aware that doing that would probably negate what we were there to do. And I said that I was comfortable not doing that because it's not my practice. Would you be okay with me pursuing with how I usually treat these, which I usually augment the dose of opioids to treat the airway obstruction to make the family comfortable and so forth. But he was left feeling uncomfortable, which I heard about for the next 3 weeks every time I saw him at rounds. And I think both those stories and both of these physicians, the point is that it's not the same. And why do people keep telling us that it's the same? And that's sort of what was the point of the research, is that how can it be? The first thing we don't think about is that, and maybe this is my practice or how we do it in Montreal, but I don't attend the withdrawals. I mean, I speak to the family, I meet with them, I write the orders, I check in, I come back, but usually the nurse is at the bedside, in all honesty, and I give her leeway or him leeway to dose the patient as they feel is needed. But here we are, we're at the bedside, and I must say it's a different experience. Just that in itself will lead to a different experience in itself. And so we can't go on telling ourselves that it's the same. And I think the tension is that there's the tension as you described by the family and your own personal expectations, but the tension is that the frustration of that this should be the same experience, and it's clearly not. And I think it's important to have an honest conversation about that. And so I think that really informed my work. I really felt lucky to be able to work with the DPART database to get a chance to look at this actually in some data and to help inform these experiences. Thank you.
Thank you. Andreas, I'll give you the privilege of the last word. We've known each other a while, and I always appreciate your perspective. And when we had this call, you talked about not only are there different perspectives, as Paula has pointed out, for who's involved, but there may be different perspectives across our country. And so I give you a chance to summarize some of what you've heard and add things that maybe we've missed. Sure,
thanks. Yeah, DCD is a complex kind of journey process for healthcare professionals and patients, and there's of course a number of steps that can generate tensions, beginning at the neuroprognostication conversations through to the consent and the withdrawal process, the issue of premortem interventions like heparin, or would you do an organ biopsy in order to determine viability in a patient who isn't deceased yet, all the way to the declaration of death and how death is defined. So those are all potential tensions in DCD. I think I come at this as the medical director of an organ donation agency in a fairly late adopting part of the country, with our first DCD case having been in 2016, and so we had to decide on eligibility criteria for who are we going to start with to consider for DCD, and so we started fairly restrictively, I would say, compared to other parts of the country, and now with, I think, 3 to 4 years of success, I think we're looking at expanding who we would consider offering DCD to, and I'm quite excited actually about the type of work that Jason's doing, because this is a really tough issue. In my experience, a really large proportion of potential DCD donors are, for example, a patient who's post-cardiac arrest, day 5 or 6. They might, they're of course still deeply comatose, but they tend not to have a lot of other organ failure. And so they might be on a very minimal amount of life support, 7 of pressure support, 5 of PEEP, 30% oxygen, decent cough. And so I get calls about patients like that, and it does create tension in terms of, should we offer DCD in this situation, because there's two sides to this, right? On the one hand, our organ donation rates aren't as high as those in Ontario. Andrew and team make us look bad, right? And so there's you want to maximize donation opportunities. You want to respect the autonomy of patients. All those good things that we hear at forums on donation and transplantation. But on the other hand, if you believe the DCD-N score, which is an imperfect prediction model, fairly simplistic one actually, the patient I just described probably has about a 10-20% chance of dying within 60 to 120 minutes. And if I do go down the DCD pathway, I will be prolonging the death of that patient. They will be in the ICU for an extra 2 days probably. They may experience some discomfort during that time. It can be very hard on their family, who's maybe looking for closure, even if they want donation to happen. I need to reserve an OR. The transplant surgeon may need to cancel some of their other cases. I may need to, if there's lung procurement that's going to have an anesthetist on standby to re-intubate the deceased donor in the OR. If we're going to procure lungs, my center doesn't procure or doesn't recover them. So we have to have a team come from Edmonton to recover thoracic organs, et cetera, et cetera. It's a huge resource investment, and so there's this tension. What's the right thing to do? I mean, if I know there's an 80% chance that the patient's actually going to die in that time frame, I think everybody would go ahead, right? If it's 50%, we'd probably go ahead. If it's 10%, I don't know. I mean, certainly, whatever you do, I mean, I think it's crucial that we be transparent with families about this right up front when we're having the donation conversation in the first place. And sometimes maybe there's too much emphasis on having an affirmative consent as being the desired outcome of those conversations too, instead of necessarily what the right thing is for the family. That's going to have a durable, lasting, positive effect.
Thank you, Andreas. I want to give the panel a couple of minutes if you wish to respond or comment on each other's presentations, and then we've left lots of time to open it to the floor, which is what I was really hoping to do.
Maybe just a comment, and I think Andreas some really, really important points there. And one of the things that I would just highlight is that concept of time. And we talked a bit about this yesterday and what time means for a family member. And I think we have to be really careful in a lot of kind of what we feel as clinicians and what we feel a family member might be feeling might in fact be quite different. And I think that's why this research in a qualitative way is really illuminating. And I can't tell you how many family members who said, I was so thankful for the time. Like, that gave me just more time that I didn't think I would have had with my loved one at the bedside together. And some people, the time is excruciating and it's awful and waiting is really difficult, but not for everybody. And we have to really ask people and think about what that time is for them. And so just one point that I wanted to make. Thanks.